I would like to lastly add another perspective to this conversation. So we talked when we discussed about the newly diagnosed patients. I think you brought up in the beginning here, Sundar, that the patients with standard risk, they are the ones obviously that have the best outcome. And we had a discussion where we said that if you give the best drugs to those patients, that's where you're going to see the best outcome. If you give the best drugs for the patients with bad disease, they will probably need it, but the best outcome is going to be in the standard risk category. That's what we discussed. Mm-hmm. So when it comes to the relapse refractory patients, so we have so many different options. Some drugs are more powerful, some are a little bit less powerful. So I think a lot of groups are still thinking that you can use the less powerful regimens for patients who have a biochemical relapse, while those who have a symptomatic relapse, they really need the more powerful ones. So wouldn't it be reasonable to say that, extrapolating from the newly diagnosed setting, that if you use the most powerful drugs, that they would probably have a better outcome in that biochemical relapse? So to hit the biochemical relapse with the better drugs is a better long-term outcome. What do you think about that?
I think your statement is correct. If you say you want to treat patient effectively, even if the patient is relapsed, you go with an intent that you want to put the patient into complete remission, MRD negative. And I'm happy to say I have patients who have relapsed and have gone into complete remission, MRD negative, for more than 5 years. So some of the new drugs which have come, they have had excellent outcome. It was almost like the disease needed this new drug and it wiped it out, kind of a deal. So that's important. And it's also becoming very clear that we are able to get MRD negative status using drugs like CAR T-cell therapy in a patient who are penta-refractory, or 2 proteasomes, 2 immunomodulatory, and a daratumumab, and still they are able to get into complete remission MRD, and some of these are quite durable too.
So MRD happens multiple times in the same patient. It happens in the beginning, it can happen at the relapse setting, and it can last for a long time.
It may not have happened. I had a patient who went on the new drug which is approved, selinexor. That patient had never achieved remission on any of the other treatment up until then, and she had light chain myeloma, a physician's wife. And when she went on this oral selinexor, she went into complete remission. I was absolutely aghast with a single agent. So myeloma is unique in this regard. So my feeling is, going back to your question, wouldn't you treat with the best treatment for a relapsed patient rather than segmenting good risk versus high risk or symptomatic relapse versus biochemical relapse? Okay, now I can understand patient with high risk versus good risk, because that is genetic, and we use that even for newly diagnosed.
Right.
This biochemical relapse versus symptomatic relapse. A patient with high risk disease, you detect that that patient is right now biochemical, he will progress very quickly and will have a bad outcome. Yeah. So you might as well use the best treatment even though it is not a symptomatic relapse. Right. And there could be a symptomatic relapse patient with a good risk where you could actually treat with what you consider as not so intensive therapy and you get a good response. So for me, still the principle I used for newly diagnosed myeloma, what I defend as high risk or low risk based on genetic, is more important rather than whether it is a biochemical relapse or symptomatic relapse.
But could you say again, to clarify, so for a biochemical relapse, are you thinking that using the more powerful regimen for everyone, or to reserve it for those that have the genomic signature of adverse?
Yeah, I would have used a genomic signature for biochemical relapse, and I would have tackled them very effectively, because generally they are called high risk because these patients tend to relapse quickly and die early. It is the survival.
But you're saying that the biochemical relapses that don't have that genomic signature of adverse biology, you take it a little bit easier.
I take it easier. Sometimes I even watch them for a while to come to a measurable disease like we consider IMWG, then they can be on clinical trials. So I'm not concerned so much about good risk patient having a biochemical relapse as opposed to a high risk.
But you could envision a scenario, I'm not saying this is right, if there were studies done with MRD tracking, that if you hit that biochemical standard risk disease with a very good therapy, that maybe you could wipe it out, maybe you could stop therapy. So that could be another avenue of investigation.
That is absolutely a correct statement. I'll put it at that. But I have not changed my behavior, but your statement is correct.